Good afternoon, everyone. Thank you for joining us today. Welcome to ITUP's LA Health Collaborative, CalAIM implementation, funding, and operational support for community-based solutions. My name is Emily Cosillo, and I'm the Director of Programs for Insure the Uninsured project. Before we get started with the meat and potatoes of our session, I have some important housekeeping notes for you. First off, this webinar is being recorded, and it will be available on our ITUP LA Health Collaborative webpage after the event. Attendees can listen to this webinar through their computers or by dialing in using the number and passcode provided by the Zoom software. We also welcome you to utilize the closed captioning function. Just click on the CC button at the bottom of your screen to enable the live transcription feature. Today's webinar will run approximately 1 hour and 30 minutes, and we'll have 2 main panels, each followed by a question and answer session. If you do have questions during the webinar, you don't have to wait until the end of each panel or presentation to submit. We encourage you to submit your questions using the question and answer panel, which you can also find at the bottom of your screen. When submitting a question, please indicate if it's directed at a specific speaker. We will answer as many questions as we can throughout today's webinar. Also located at the bottom of your screen is the chat panel. Please feel free to use this chat function to say hello or chat with other attendees. We will be posting relevant information and links throughout the webinar here as well. And now it's my pleasure to hand it over to ITUP's Executive Director, Katie Hydarn, to get us started. Katie?
Hi, Emily. Thanks so much for the housekeeping, and hi, everyone. Welcome. We're so excited to have you all here today to talk about CalAIM. We had a chance to talk with some of our panelists about a year ago, and so I know we're really excited to get an update from them, as well as hear from a representative from the Department of Healthcare Services at the state level about some updates on their end as well. So before I get started, I'm just going to share my screen here and tell you a little bit about ITUP, and then I'll introduce Susan. So thanks, everyone. Bear with me just a sec as we get this up. There it is. So again, welcome. And just a little background about ITUP. We are a 25-year-old health policy organization, and our mission is to promote innovative and workable policy solutions that improve healthcare access and the health of all Californians. We believe that all Californians should have an opportunity to live their healthiest lives, and we seek a healthcare system that is universal, equitable, accessible, effective, and affordable. Before we jump in, we wanted to get a little bit more info about your interest in CalAIM. So I'm going to invite Emily to put up the poll. Should be just a couple questions, multiple choice, and really appreciate it. It's our way of just gathering a little bit more information from our audience and making sure that we're bringing you the type of information that you want to see. Give it just a second. All right, thank you all. Really appreciate you providing that feedback. So just a quick agenda overview. We're going to have a great presentation by Susan Phillip from the Department of Healthcare Services. Susan, thank you so much for being with us today. She's going to talk a little bit about some of the new information on the exciting funding opportunities to support CalAIM implementation. And then we'll have folks who are working in LA, our 2 health plans, LA Care and HealthNet, as well as representatives from health centers and community-based organizations talking about what they've done, what they've learned, and what their forecast looks like for the big items coming up ahead of them in 2023 in the CalAIM arena. So with that, Susan, I'm going to stop sharing my screen. I'll let Emily start to share your slides and we'll get going. Thank you again for being here today.
Great, thanks so much, Katie. Hi, everyone. Thank you so much for having me today. It's really a pleasure to join you. My name is Susan Phillip, Deputy Director for Healthcare Delivery Systems at the Department of Healthcare Services. And as Katie mentioned, I'm really here to provide an overview of a couple of funding opportunities under the CalAIM initiative. And I'm going to spend most of my time on a newly launched initiative under CalAIM called PATH, which stands for Providing Access and Transforming Health. And then I'll spend a few minutes on the incentive payment program. We can move to the next slide. And I'd like to spend most of my time on PAT, since that focuses on funds available to providers, community-based organizations, counties, local health jurisdictions, tribal partners, and other local entities. And the Incentive Payment Program, or IPP, are funds paid to Medi-Cal managed care plans. Both are really intended to build capacity in our healthcare delivery system to really achieve the vision of CalAIM, and and in particular build capacity for enhanced care management and community supports. So I'm going to go through that, and then hopefully we'll have plenty of time for question and answers at the end. Before I get started, I did just want to have a quick reminder on what enhanced care management community supports is. I know most of folks in the audience are already familiar, but just as a really quick reminder, enhanced care management is a new Medi-Cal benefit under CalAIM designed to support comprehensive care management for members with complex needs. So, individuals with high needs, often have to engage the delivery system to access care in multiple settings across different delivery systems. And so enhanced care management is really intended to address clinical and non-clinical needs of these highest need enrollees and provide that intensive coordination of care for health and health-related services, and really intended to be high touch. Community supports are a set of services that Medi-Cal managed care plans are strongly encouraged to provide, but not required to, I should say. And these are considered, potential substitutes for other services such as hospital care, skilled nursing facility services, or emergency department use. The whole idea of community supports is that they're really intended to be cost-effective alternatives to other healthcare services which are medically appropriate. So there are 14 pre-approved set of community supports. So I just wanted to remind folks of that, because PATH is really intended to build capacity in our delivery system to scale these services across the state. So we can move to the next slide and to the one after that. Great. So as I mentioned, PAT stands for Providing Access and Transforming Health. And the department received authorization for $1.44 billion for PATH. And again, it is that the dollars there are to maintain, build, and scale the infrastructure and capacity necessary to really ensure successful implementation of ECM and community supports under CalAIM. PATH is really intended to complement and enhance other CalAIM funding efforts, and really shouldn't be necessarily considered a primary source of funding since it is limited time. And I would think of it as like startup money, if you will. So it's really intended to provide that initial infusion of funding support to develop capacity. So as I mentioned, the PATH funds are really intended to go to CBOs, providers, counties, local health jurisdictions, tribal partners, and really build that capacity directly to partner organizations. Managed care plans would not be eligible to receive funding under PATH. And as I mentioned, there's other dollars for managed care plans through the IPP funds. I will also note that we are seeking an additional $410 million to support implementation of certain set of initiatives under our justice involved initiatives, specifically for pre-release services. So those are some funding that we're seeking and waiting for approval from CMS on. So we can move to the next slide. Okay, so there is quite a lot of information to get through. So, and this slide kind of provides a snapshot of the key PATH program initiatives. I really want to spend more time on the 4 with the asterisk next to it. But just really quickly, the first initiative is the whole person care services and transition to managed care. As you all know, enhanced care management and community supports was designed to build on scale those services that we can take statewide, and they're really these dollars, the whole person care services and transition dollars, were really intended to transition those services that existed under whole person care pilots and have them transition to ECM and community supports that managed care plans have committed to cover by 2024. So that initiative is well underway. The second row here is the Justice Involved Capacity Building, and this is funding to support collaborative planning as well as infrastructure and capacity building needed to maintain and build pre-release enrollment and suspension processes. The next initiative is Collaborative Planning and Implementation Initiative. These dollars are really intended to support collaborative planning and implementation among providers, community-based organizations, counties, public hospitals, tribes, and managed care plans, and really bring them together in groups to really engage in that planning for that community. And the idea is to really promote readiness for ECM and community supports. The next path initiative is Capacity and Infrastructure Transition, Expansion and Development Initiative. It's easier to say CITED, which is the acronym we're using. So these dollars are intended to really enable transition, expansion, and development of capacity infrastructure, really for providers, again, CBOs, and local entities, to really provide ECM and community supports. And we just launched this initiative as of August 1st. And then finally, we have the Technical Assistance Marketplace Initiative. This initiative is really to provide dollars as well as a pre-approved set of technical assistance vendors who could provide technical assistance to providers, again, CBOs, all those local organizations that might really need that technical assistance to get their ECM and community support services, infrastructure, and services off the ground. And this one will really take kind of the biggest lift, and we expect this to come online early in 2023. So for the ones next with the star next to it, what DHCS has done is we have onboarded a third-party administrator to help us administer these initiatives. So the third-party administrator is Public Consulting Group. They started on July 1st, so just a couple of months ago. And so the TPA is really working closely with our DHCS team and with stakeholders to get these initiatives underway. And the Public Consulting Group really brings a large implementation support team to really help us administer these grants and since it is such a large scale program, and they have the capacity for doing that in other states as well. So we can move to the next slide. Okay. So, and just the third-party administrator, just saw a question come in, that the name of that TPA is called Public Consulting Group. Okay, so this slide gives an overview of the timeline. So as I mentioned, collaborative planning, that is the first initiative that really is, and I'm going to go through each of these in even more detail in the next few slides. But that launched in August, and we intend to have funds to start being dispersed in September. So we are underway for that initiative. CITED also launched in August, and round one of that application window is now open. And see, the application window is 2 months, so running through the end of this month. And we expect to start dispersing funds based on those applications by the end of the year. And as I mentioned, the TA Marketplace will be launched early next year. In terms of Justice Involved Initiative, the round one applications were opened. We're now in round two, and those funds are to be dispersed on a rolling basis. And again, I'm going to get into each of these in much more detail shortly. Okay, so let's move to the next slide. All right, so there are 4 slides here. I'm going to cover each of the 4 that I mentioned. First, Justice Involved Capacity Building, Collaborative Planning, CITED, and then the technical assistance. So as I mentioned, we have $1.44 billion for PATH as a whole. We have 151 million specifically for justice involved capacity building. And these dollars are really intended to support collaborative planning and IT investments to support the implementation of the justice involved pre-release Medi-Cal application and suspension processes. So ensuring that as folks are, before they're released from jails and prisons, that they are enrolled in Medi-Cal, or if they're going to be in jails for a short period of time, that their Medi-Cal eligibility is maintained. So these dollars are really intended to support correctional institutions, correctional agencies, and county departments of social services as they develop protocols and workflows and implement IT systems. For example, there might be a need for IT system upgrades to really support that pre-release enrollment and suspension process. So those dollars are really intended to help build that kind of, tangible capacity needed on the ground. The funding will be available in 2 rounds. The first is to provide that small planning grants, and the second is much larger grants to support implementation, modification again of those IT systems. As of now, DHCS has approved about 4.2 million in grants during round 1 of the PATH Justice Involved program. And this funding is supporting 38 sheriff's offices and probation offices from 34 counties across the state, as well as the California Department of Corrections and Rehabilitation. And then all these correctional agencies together are responsible for 110 adult jails and youth correctional facilities and 34 prisons across the state. So these dollars have already gone out and beginning to, really support that planning effort that's needed. So the next initiative under PATH is related to collaborative planning. As I mentioned, we're working with a third-party administrator right now, and currently what we're doing is identifying facilitators that could really support that regional collaborative planning effort. So the idea here is that the funding will support a designated PATH facilitator in each county or region. And we really want these collaborative planning efforts to build off of existing collaborative planning efforts, to the extent feasible. So for example, under ITUP, which is the incentive payment program, as I mentioned earlier, under that program, a gap filling plan was developed at a community level. So it would be good to ensure that the collaborative planning effort takes into account, what does a gap filling plan say? What are the efforts underway under the gap filling plan? What are the needs that the community has already identified? And what additional gaps and needs does the community together decide they want to address through their collaborative planning and implementation initiative? And of course, these are all grounded in building capacity for enhanced care management and community supports. So right now, DHCS is in the process of soliciting and reviewing applications for the collaborative planning group, the facilitators, and launching those collaborative planning groups. And so on this slide, you'll see a link here for anyone. I'm sorry, we should go to the next slide there. Okay, here we go. So here we see the participants can register on this link here. In the box, you see participants can register at this link. And so that's where, if you're interested in raising your hand and saying, I want to be part of a collaborative planning effort in my area. So, and that's where you can register. And then what we will do is take that information and look to see the facilitator that we're considering for that region and do that matching effort. Okay, so we can move to the next slide. Okay, so this the next PATH initiative is cited. And this is an application-based initiative. So eligible applicants would include organizations that are contracted to provide or that intend to provide ECM and community supports and are really looking to, have funding for that specific infrastructure and capacity building efforts that they need. So again, organizations that could be eligible are counties, local governmental agencies, public hospitals, providers, CBOs, tribal partners. And so, really looking to have a large swath of organizations that could be eligible. Applicants do have to meet a minimum eligibility criteria. And really that includes first completing an application and through the application process, the application must demonstrate that the funding request is reasonable and attest that that fund will be only spent on permitted uses, and get into that a little bit here. The application will request information again on intended cited funds and how they're going to be used. So the application should clearly explain, what is the purpose of the funds, what's a sustainability plan for future funding, and how there won't necessarily be duplication of funding. So how will duplication of funding be avoided? So permitted uses include actually quite a large variety of uses. So it can be used for IT systems, developing processes or systems that are really needed for building that technical capacity. It could be used, for example, for developing and modifying like referrals or workflows and those sorts of systems that are needed to support those processes. Billing systems, for example, it could be used for increasing provider workforce. So dollars may be used to support salaries to a certain extent. And so that is a permitted use of funds. So all of that is laid out in the application and the application guide, and the parameters are spelled out specifically there. Cited may also be used to be used for retroactive funding to support investments in infrastructure and capacity that may have already been made to support ECM and community supports, as long as those were investments made after January 1, 2022. Of course, within certain guardrails. So there are some strict guardrails and requirements, but as long as it was after January 1, 2022, it can be included in the application process and will be considered. I did want to mention also that, in terms of how the cited dollars will be allocated, we are looking at multiple application windows in each year. And the idea is that we want to make sure that first, there's a substantial amount of time for folks to have that application, but we also want to make sure that we're providing opportunities for organizations, say, for example, who might not be ready for this round, but might be ready, a few months from now, early next year, to say, hey, it wasn't ready, in the August, September time period of 2022, but we want to make sure that we get our application in the next round, and then that's permitted. We want to make sure that we're thinking of how to allocate the dollars, not just to organizations that are super sophisticated and know how to fill out an application on day one, but for also those organizations that need that extra help and that technical assistance to fill out an application. So a big part of the TPA's job and their charge is to actually support organizations that are interested in filling out applications. We've had a webinar, for example, that kind of walks through that process, and the third-party administrator is available to support organizations that are interested in going through that application process and really helping them through the nitty-gritty of actually going through that process. Okay, we can go to the next slide. All right, so then we have the technical assistance marketplace. And the idea here is that there are entities, that really need that technical assistance. For example, they might never have contracted with a managed care plan before. So how do they do that? So the idea here is our third-party administrator will vet and contract with technical assistance vendors. So there will be a pre-approved set of technical assistance vendors that can then provide that technical assistance to CBOs, providers, et cetera, any eligible entity that wants to raise their hand and say, hey, I need some additional technical assistance. So that this will be a marketplace where the organizations that need that technical assistance can find the TA vendors. So this will require quite a big lift. Right now, we're in the process of identifying TA vendors, going through a process of vetting them, and then we're looking to stand up the marketplace as of January of 2023. We are in the process of thinking through different types of domains that TA vendors would be, be selected in. So if there's specific areas that you think, hey, we really need TA assistance in this area, we're very open to suggestions, especially right now at the planning phase. So please do share any specific areas of technical assistance that you believe is needed and would be well supported by the TA marketplace. Okay, so then I know I just have a couple of minutes. So I did just want to touch on the incentive payment program. We can move to the next slide. Great. So, so the IPP program is really a voluntary program for health plans to really support implementation expansion, again, of ECM and community supports. And the idea here is we really want to support investment in the delivery system and capacity building really at the provider level. And we've had multiple managed care plans raise their hand and apply for this. What they had to go through the process of working with their communities and developing gap filling plans and submitting that to DHCS. Again, the idea here is, we want to ensure that the dollars go really to building that provider capacity, breaking down those silos, which is really ultimately the vision of CalAIM, right? Bridging those silos between physical and behavioral healthcare services, reducing healthcare disparities, promoting health equity, driving that quality performance that we want to see our delivery system deliver, and really increase take-up and offer of community support services. We can move to the next slide. So this slide shows, the priority areas under IPP. So in terms of delivery system infrastructure, the dollars are intended to fund core managed care plan efforts, network provider efforts, to again develop ECM and community supports provider capacity building. And this includes health information technology, data exchange infrastructure. And so it's just again, dollars flowing through managed care plans to build out those services. Dollars may also flow from the managed care plans to ECM providers to support ECM workforce training, technical assistance, and really support that development and operational set of requirements and oversight needed for ECM and community supports. And then, as I mentioned, dollars may also flow from managed care plans to community support providers to, again, support the training, TA, and whatever's really needed to support that community supports development, training, and infrastructure. So as of April of 2022, DHCS issued the first IPP payments totaling $300 million statewide, and about $80 million was issued to LA County managed care plans. And we do, there's about $1.2 billion that is allocated for the total program through June of 2024. So that is the total amount that we have authorized by CMS for these dollars, and about $300 million has already gone out the door there. So I think I think that's all we have time for, and I will, I've already addressed most of these, the items on this slide, so we can just move to Q&A.
Susan, thank you so much. That was a fantastic presentation filled with a ton of information that I know I'm still trying to digest, and I learned so much. So I know you've been providing this information to folks, so thank you for joining us to share it with this audience as well. We do only have about 5 minutes for question and answer, and I know we could talk for hours about this with everybody on the line. So just for folks who are putting questions, please use the Q&A function, not the chat function. If you put something in the chat, please put it in the Q&A function, because that's really where we're pulling questions from. And I'm going to try and just pull out a couple key pieces, key questions here that maybe aren't quite answered in the slides. So I think there are a couple questions here about what happens if you're applying to be a CalAIM provider or site. And then what happens if you apply, get funds, and then ultimately don't wind up contracting with a managed care plan? Can you get the funds if you're applying but haven't yet been designated as a CalAIM provider? And then what happens if you ultimately get funds but then don't wind up contracting?
Well, so for cited specifically, that is specific to organizations that are intending to be an ECM and community supports provider. So we didn't say that you must have a contract at this point, but there needs to be an intention to provide ECM and community support. So that is right now what the guidance is. In terms of what happens if ultimately it doesn't work out. I mean, it's a great question. I think that's something we'll have to take back. But again, right now, there has to be a demonstrable, intention to actually provide ECM and community supports. For collaborative planning, that really is, again, it's planning, right? It's identifying what services and gaps are needed in the community, where there's real opportunity for developing ECM community supports, and really bringing folks around the table to do that planning effort. So in that sense, again, the dollars are going to go to facilitators, and those who register will be part of the planning effort. For the TA marketplace, again, it is intended for organizations that are looking to be ECM and community support providers and looking for that specific TA assistance. So again, same answer as for the cited. So at this point, it's really about what is your motivation? Are you fully intending to do it? And is that demonstrated in your application?
Great, perfect. So I know you said it briefly, but can you remind us of the name of the third-party administrator? And I know you have the link in your presentation, but can you just remind folks listening how they connect with them
absolutely.
directly?
And I can also send around all the links both to the TPA site as well as our site to navigate to that. But it's Public Consulting Group. So that is the name of the organization. They're a large fiscal intermediary that's provided grant making in other states, and they've been they've hit the ground running. They've had quite a big lift since in July.
Perfect.
Yes,
and and we've had several questions. These slides will be available along with all of the links in them, so those will be there for everybody. And let's see. I think. Two last questions. Is there a maximum amount of funds that folks can request? This particular person who submitted the question said they're a nonprofit and implementing several services in 2 counties.
We haven't said that there's a maximum. So for example, for cited, this is one of the reasons we have application windows. The whole idea is, we'll be looking at the applications kind of in whole, right? So we'll be getting applications from different organizations in different regions. And we want to make sure that we're looking at how we're allocating those dollars as a whole. So your application will be examined, in the context of the other applications that do come in as well, because our intent is to allocate dollars in an equitable fashion, make sure that we are spreading dollars, right? Not just to regions that, might raise their hand, but there's also dollars still available for those regions in California that might need the extra capacity building, but but need a little bit extra time. So we need to make sure that we're spreading the dollars over the next couple of years evenly.
Absolutely.
But right now, there's no explicit limit.
Got it. Thank you. There are so many other questions, but maybe just to wrap this up, since you went through multiple different funding paths, and I think you mentioned multiple times that some are through managed care plans, some are through the department directly. And I know you all have this presentation, so you can go back in, but can you just remind us how the IPP funds are different from cited, and could somebody apply for both IPP funds?
Okay, so the incentive payment program, those are dollars directly to the managed care plans. So the managed care plans had to go through a whole process where they had to submit gap filling plans. We've reviewed them. We've been working with them to understand how they're working with their providers to ensure that the dollars will be actually flowing to their ECM and community supports providers. And so that's specifically DHCS dollars to the managed care plans. PATH is directly to the providers. And from DHCS. So managed care plans are not eligible for PATH dollars.
Great, thank you. So with that, as we said, those slides will be available. Please review them. I know that Susan and her team have an email address. If you have any questions, you can always email them with additional follow-up questions. Susan, thank you so much for bringing all this to us. I know there are a lot of questions around funding. We've just scratched the surface, but really appreciate you providing all of this great information. And thank you so much. We really appreciate it.
Yeah, thank you all for having me. I know it's a lot of information, and hopefully it was digestible, but definitely the deck will be available. And of course, feel free to reach out to us at DHCS directly or to our TPA as well. Thank you again.
Thank you. And seeing some thank yous in the chat too. So Susan, greatly appreciate it. Lots of thank yous with lots of exclamation marks. So thank you again. All right. And with that, I'm going to invite our next panel to come up and talk. So I think everyone has their videos on and ready to go. So first, I really appreciate Susan sort of framing all of the funding opportunities and capacity building. We're really going to sort of take a deep dive into this here with the group that we have on screen right now. And I think you'll get to hear how some of those IPP dollars in particular are helping transform folks who are participating in ECM and CS. So you can hear real time how people have used those dollars and how they're using them to build towards broader, systemic reform. So with that, I think I'm going to start with, I'm going to let you all introduce yourselves because you can do it so much better than I can. I'm going to start with our couple of health plans to help just frame the work that you've already done. And then we'll go to Heidi and then to Anwar. So if you want, go ahead and mute yourselves while your fellow panelists are talking. And I'm going to start with Cynthia. Cynthia, please go ahead.
Thanks, Katie. I'm Cynthia Carmona. I'm the Senior Director of Safety Net Initiatives at LA Care Health Plan. And so I'm overseeing implementation of both enhanced care management and community supports at LA Care, and I'm happy to be here.
Thanks so much, Cynthia. Karen, you want to go ahead?
Certainly. Hi, good afternoon. Karen Richmond. I'm the Regional Vice President of the Medi-Cal Program for HealthNet, and very happy to be here on this panel today. A little bit about HealthNet. Locally, HealthNet serves more than 1/3 of Angelenos enrolled in the Medi-Cal program and has done so proudly in Los Angeles since 1997. We really were excited to be a part of the CalAIM launch and developed a robust network of community-based organizations, housing agencies, county partners, tribal partners, and others. We are now offering all 14 community supports. We have a roadmap to offer all 14 community supports by 2023. And we have contributed more than $100 million to more than 500 community-based initiatives as we were building the foundation for CalAIM. So really believe in a history of local engagement, investments, and partnerships has positioned Health Net as a trusted partner in the community. Personally, I've been involved with the launch of CalAIM alongside with Cynthia for probably the past 2 years, and really have enjoyed connecting with each of the organizations contributing to the care of our members. Grateful to be asked to speak with you today and to share the panel with our fine partners. Thank you.
Thanks, Karen. And again, I know how closely you and Cynthia work together. So this is probably not the only call you have together today. And I know you work very closely with the county as well. So thank you. Heidi, why don't you go ahead?
Hi, everybody. I'm Heidi Lenartz. I'm the Chief Operating Officer at San Fernando Community Health Center. We are an FQHC located in the northeastern area of the San Fernando Valley in Los Angeles, and been certified for FQHC for about 8 years. In 2019, we joined Health Homes with LA Care, and we were by that time fairly integrated with behavioral health, medical, dental, really building our specialty services for over 7,000 members within the community, a largely Spanish-speaking community, about 80%. And Health Homes was very exciting. It was transformational for us, so I'm looking forward to talking about that. We've since, used a lot of our teachings and learnings and funding to really begin to build out more and more of our capacity for this. So we're looking forward to sharing that today.
Thanks so much, Heidi. And Anwar.
Good afternoon, everyone. My name is Anwar Zuhaid. I'm the Vice President of Long-Term Services and Supports. And Partners in Care, we're a nonprofit agency. Our mission is to align social care and healthcare to address the social determinants and health equity and disparities. We do that by providing complex care management, evidence-based health education, both directly and through our diverse group of statewide CDO community hub partners. So I personally oversee the Medi-Cal home and community-based services, including the MSSP, CDA, assisted living waivers, along with CalAIM, enhanced care management, and community supports. And we started our journey with CalAIM. Well, we were a Health Homes provider, so we kind of grandfathered in, and we've been really key stakeholders to help really design CalAIM. So dedicated a lot of my life and my career to serve the underserved communities, and I see CalAIM as the 5-star initiative as of yet in over 24 years of my experience. I'm excited to be here today to share our experience, our thoughts with CalAIM. I think we have a once-in-a-lifetime opportunity to ensure its success. So thank you for having me.
Yeah, Anwar, thank you. And thanks for underscoring just the magnitude of this initiative and that we're just getting started. So I know we had this conversation with Karen and Cynthia and a couple others about a year ago. And so really glad to add you two to the panel and to see where we are and check in a year later and see what's coming up. So let's jump in. We have some discussion questions I'm just going to put up so that the audience can see what we're going to talk about. And then we'll just go around the virtual room here and discuss them. So, 1 year in to ECM and CS, would love to hear from each of you, and it's probably different because you're representing different perspectives here. What were and are, some of those real pain points? How do you overcome them? How are you working to overcome them? And were DHCS's, ITP funds provided through the plans helpful? And don't worry, we'll get into actual specific capacity building strategies and outreach and enrollment in a minute. So pain points. Let's see, who'd like to start? Heidi, go ahead.
Yeah, I'll go ahead. I think our initial pain points were building the healthcare information exchange, really integrating lanes, integrating collective medical, creating bidirectional information sharing with hospitals, clinics, other facilities, patient rosters, HIPAA compliant systems. So we've launched some care messaging and texting platforms that really we have to work those issues out. We've also had to learn the portal access. Really, it was the first launch of an SFTP with a health plan that was important for us, and that's created a whole other information exchange with the health plan directly that's been actually really, we felt productive. There's always kinks to work out, but those were the initial pain points for us. And also training, really creating some rails and workflows for new and developing staff. Workforce development, which we'll talk about, has been a real support from a lot of the training and education and certification through the health plan has really helped us in that regard. But those initial times when we were really getting everybody oriented to the program took time and took effort and detailed work. So.
Thanks, Heidi. Anwar.
Yeah, so similar to Heidi's and I think other CBOs, we also found a need for extensive need for collaboration with other providers. The need for consistency among the health plans and providers, including the reporting requirements, operational workflows, the model of care we've noticed is a little bit different from one provider to another. One of my, I was going to say favorites, but it's actually least favorite because it's a bit sad. It's the population that we're serving really lacks trust. They have been hurt. They have lifelong trauma history. They've been full of empty promises in the past. So we always had to be creative, find ways to relate to the participant. That includes having a diverse group of staff who really have real life lived experience, and it makes it easier for participants to connect. Continued enhancement of our outreach and engagement process. I think that's really key, like Heidi mentioned. Phone calls, letters, texting, unannounced home visits, locating members through coordination with the PCP's office, collective medical, homeless management information system, and coordinated entry system. We kind of take a whatever it takes approach because it's still in the initial design phase of CalAIM. What was put in policy doesn't necessarily always work out in the community. So we try to make sure that we do whatever it takes to engage these members. Employee retention has been a challenge, and I got to be honest with that. We had to come up with new innovative ways to retain employees, recruit new employees by giving them new incentives and making sure that their onboarding process through workforce development is really optimized so that they don't feel burned out. And then just specifically about the community supports, we found that medically supported meals and tailored meals, really that was no issue at all to implement. Providers really have stepped up. Home modification, a bit harder because of the lack of licensed contractors. Personal care, staffing workforce shortage, it's been an issue as well. And let's see what else here. I think with community transitions to nursing, we're still working that out for the January launch. So, yeah.
Great, thank you so much for underscoring all of that. Let's see, Karen.
Thank you. I appreciated the perspective from Anwar and Heidi, and hearing just the level of sophistication of the types of highlights that you shared. I think what I would say is as one of the main challenges has been just there is not consistency with that level of sophistication across organizations. So really coming together and collaborating with the managed care plans in Los Angeles, primarily with LA Care, to ensure that we look at tools and how to provide operational simplification, lessen administrative burden where possible, understanding that there is a continuum here of different organizations that have a different level of sophistication, and maybe sophistication is the wrong word, but a different level of maybe even technology infrastructure, workforce capacity. And so really meeting and understanding what are the needs of these community-based organizations, because they are not the same, how we can assist them in engaging with the managed care plan, how we simplify the tools and processes, and then how we also explain that there are some distinctions with the managed care plans that are unique. And that might be, obviously things like a portal, how we may all have different types of portal connectivity. And so really giving education and training around those tools and processes. And that needs to be ongoing. That cannot be something that we just provide one time. As you heard, there can be staff turnover. As we dive deeper into enhanced care management and community supports, it's kind of the next layer now of things that we're uncovering, best practices that we can revisit. And so we continuously need to be in communication with our community-based organizations and county partners, understanding the challenges that they continue to face. And we continue to work on, even today, revisiting tools and how we can simplify things now that we have more guidance and more understanding of how the programs are actually rolling out.
Yeah, Karen, thank you so much. And you touched a little bit on some of those strategies for building out the capacity. And so Cynthia, maybe you can talk a little bit about pain points, but also build off of what Karen said and get us into that workforce development capacity building conversation.
Sure. Yeah, so first of all, I would agree with, the things that Karen said. And when we talk about sophistication across providers, I would add to that, not just on the technical aspects, but also, it is related, but privacy and security requirements that come with things like being HIPAA compliant. Those are things that I think a lot of the primary care providers are used to doing, but the other kinds of providers, the community-based providers who haven't always been in the health space, that's new to them. And so that is something too that's just an example of another area where we've had to kind of go back to the drawing board and think, okay, how are we going to help with that piece too? I think a couple of the other things I would mention are just the scale and scope, especially being in Los Angeles County. With the plans being, strongly encouraged to offer all 14 of the community supports, that's, a pretty heavy lift. And I think that's why you've seen a staged rollout of things, because the community supports aren't all operationalized the same. They have different structures, they have different payment models. And so those are all things that have to be worked through and kind of internally and ramped up to launch. So that's why you're seeing kind of like it taking a minute for everybody to get to that 14. And then I would just say also, I think we all recognize that when you're launching something new, there are going to be kinks, there are going to be hiccups, there are going to be, barriers that you have to address, tweaks, make some changes. But I would say, and I think there's been really good communication with the department, between the plans and the department, in terms of how things are going. But sometimes when there are changes, it just, you build something one way and then there's a change and your folks have to go back and make changes. And it just kind of upsets the apple cart in terms of all of the other projects that are being staged in the managed care plan, right? So we're not just talking about ECM and CS. You know, the health plans are also doing PHM, and some are doing DSNP, and some are doing all these other really major projects. So it's been really tricky to kind of stage all of those in a time frame that, you know, where they can be successful, you know, at all of them. So when you come in later, like 6 months post-launch, and say, oh, okay, well, actually, we're going to do this. You know, it's like, you know, and everybody has to go back to the drawing board. So that, I would say, that's been another kind of internal discussion, I guess, from a managed care perspective. From the workforce side, absolutely recognizing that's a challenge, both for the providers and at the managed care plans. You know, we're not immune to that turnover that was expressed earlier. And it's, you know, making sure that we have the people on hand to do all of those things that I just talked about. But it's also, you know, and I know we'll talk about IPP, you know, how can we help get some more resources out the door to help our network kind of ramp up for that, especially when there is this expectation that the plans continue to increase enrollment, continue to grow their networks. How do we make sure that we're working together with those providers in order to do that? So I guess that's my 2 cents, Katie, on the workforce piece. I think there's a lot we could talk about there, but I will stop there. Those are some of the key thoughts that I had, I think.
Thank you, Cynthia. That's perfect. You know, let's go to Heidi first and then Anwar. What have you used those IPP funds for, and do they go to training and readiness activities? What's been the most important use of those funds, Heidi?
You know, we've used a lot of it to deal and address provider burden. You know, a lot of education, training for the providers, readiness, you know, in terms of, you know, even, I mean, it sounds simple, but being able to allow dictation services for providers. I mean, these are small things, but, you know, this whole program is a heavy lift. And so when you're looking at complex care management and caseloads for providers and specialty levels of care and integrated, others integrated specialty services, collaborating with outside entities, you know, the provider burden is pretty enormous, and we're looking at that very heavily. But even for, you know, the non-physician providers, behavioral health, dental, these other services that we're trying to integrate, you know, I think giving them the full picture also by educating and training them on what the program, whole person care training. And we've really utilized the workshops with both health homes and ECM and now CalAIM leadership development. That's a huge teaching environment, I think. We've really focused on internal staff development, developing providers as well as internal management development, and retaining staff more than we have been successful at bringing new people in this last 6 months. It's been very, very difficult provider recruitment for Spanish-speaking providers. It's been enormously difficult. We've just hit a wall. So that is where we want to go. We want to continue to address supporting the providers and the teams in whatever way we can while we're continuing to build this out. You're right, Anwar and Cynthia and Karen, this is an ongoing evolution. It's not, there's fits and starts. And so we're going with the flow and being patient, I think, too, for ourselves, but also trying to support the caregivers and our clients too in the process. So really trying to
I'll go next.
Yeah, sorry, Anwar. Heidi, I think somehow you got muted. Sorry about that. Anwar, go ahead.
Well, I gotta say, never in my entire career have I ever seen so much resources being put into how community-based organizations really lift up and serve this population. For many years, community-based organizations have been saying, we're the experts, We've been here for many, many, many years. We know the resources within the community. We know how to coordinate the care. And we've been heard. One thing is that community-based organizations don't necessarily have the capital to really scale up so quickly as CalAIM is demanding. So and historically they've been they have to subsidize the programs in a way where they would borrow staff from another seasoned or mature program in order to scale up. But this has been totally life-changing. And I can't emphasize how much the health plans, specifically HealthNet and LA Care, how they work together to really hear us out and what do you need? Here's the money for it. And it's just been really helpful to help us scale. And one of the first things that we utilize that money is to really be proactive. That's the main word here, is proactive, not necessarily reactive in terms of onboarding staff and all that, but it was the really proactive approach to onboarding, training staff, and that would be our number one use of that money. But of course, the tools needed to operate such a huge program, care management software, the security settings for that, the intake outreach, assessment, care planning, all that goes into that, the metrics and quality assurance and encounter data, computer hardware as well. We were able to leverage those funds to purchase those items and other operational expenses. And again, typically that CBOs would subsidize. So it's been a huge difference for our agency and other agencies. And I really thank HealthNet and LA Care for all their efforts and really scaling us up to make this successful. And it has been successful.
Yeah, Anwar and Heidi, thank you for talking about how valuable that partnership has been, that once you really are onboarded as an ECM or CS provider, that partnership with the health plan, it doesn't just end with a contract, that there's funds and problem solving that are going on. I think you all painted a picture of that. And I think that's really of interest to those of us watching how this rolls out. So now that you've trained and gotten ready and gotten contracts in place, I'd love to talk a little bit about outreach and enrollment, because the whole point of this is to serve people and serve Medi-Cal enrollees. So, from each of your perspectives, are you seeing the people engaging with your communities? I mean, with your services that you were expecting? Is it slowly ramping up? And do you have any strategies that you've seen to be particularly helpful or useful? I think maybe I'll go to Heidi. Why don't you go next?
Yeah, we've actually, during this last 2 years, we've really focused on strategic outreach. So using risk stratification software that we were able to purchase with funds and really look for those high acuity, high utilizing lives, reaching out to them, pursuing enrollment. I think one of the talents that our organization has is that one-to-one trust building ability, and really face-to-face if possible, whenever they're here in the clinic, but outreach via calls and texting, obviously. But that trust building takes time, and I think, but it has to be strategic. We could spread a wide net or just wait and be more passive, but with that software, we've been able to be more strategic about it. So we have been successful. We haven't really had many gaps in that area. So we're looking to actually build and expand in regions. So, and hopefully contracts as well.
Wonderful, thank you. Anwar.
So I know I mentioned this earlier in terms of our progressive 5-state strategy for finding and engaging participants. Similar to what Heidi mentioned, you have to be consistent and aggressive in terms of really doing your outreach and engagement. We do 7 attempts by phone. We do mass mailings. We use alternative contact information by searching some of the other software systems like CHIP, HMIS, Collective Medical, secure text messaging, We also have a street outreach campaign that we initiate. One of the key takeaways is once you engage them, you have to really keep them engaged. So whether or not an outreach specialist engages them, do a quick warm handoff to your lead care manager, or if it's the lead care manager, they have to be. We've noticed that if you engage them by phone or in person through an event, but you kind of disappear for a few days, that first 24-hour period is so crucial to keeping their trust. Remember, they are hurt. They don't trust a lot of promises. They've been promised so much before. That's what we're finding. And I would say about 85% of our population, lack of trust. And also collaboration with other providers, mental health specialists, housing, the adult day healthcare center, medical groups. These are people that their PCP's office, they worked with before. So you kind of like, hey, I can work with, partners in care because they know my PCP's office. And also, I mentioned this before, diverse staff, making sure that you staff up to meet that population's diversity. I think it's so important to do that. And lastly, it's listen to the participant and make it their terms. We always have to follow the CalAIM policy, and we want to make sure we're in compliance. But if you can't do that, then what listen to the participant. If they don't want to meet at home, they want to meet at Starbucks. If they want to meet somewhere else, if they don't want to meet and just do text messaging, listen to them until you earn their trust, because it's better to make sure that you listen to them and keep them engaged than lose them, because we've noticed that once you're not engaging with them or you're not meeting their terms, they disappear quickly.
Yeah, all very valuable. Thank you. Cynthia.
Yeah, I think, being LA County, we had a big transition initially. So we saw big numbers at the outset. I think what we're looking at now is as the encounters come in, making sure that those people are seeing service, and that's taking some time, right? Because we got to get them in, and then we have to do that analysis to figure out, who's still in and who's not. So we've seen a little bit of fluctuation there, and we've talked about that with the department. From day one, there was some up and down as we kind of started to reconcile some of that out. I would say we are about to embark on kind of a phase 2 of outreach, really for those places that are not in our network, and making sure that they understand how to refer in. So I think where we're going to start is hospitals, is making sure the hospitals understand how to refer people in for various services. We've heard a lot of interest from the hospitals and questions. So I think we're going to talk internally about what we can do to be more kind of systematic and methodical with our hospital partners in terms of getting referrals in from them. I would also say we are also looking at how do we do a better job of using our internal data to identify. So so busy kind of building up the infrastructure to get everything ready to go, to start on day one. But now it's like, okay, so how do we use ECM data to get people into the CS and vice versa? What are the other data elements that we can mine to help identify people? Some data elements, right, you think are useful, but then depending on the population, it's really difficult to do proactive outreach, right? Like if you're talking about a homeless member, or you're talking about sobering center as a service, that's not really something that lends itself to data mining, but we're starting to do a little bit more of that and getting a deeper dive in that to make sure that we're utilizing that more effectively as well. And then just growing the networks. So making sure that we're periodically assessing our networks for, okay, where are we on capacity? What other providers do we want to bring in? I'm not even talking about starting a new service, but of the existing services, who do we want to add to that? I saw a question in the chat about how do you join the network? And I think, I'm always happy to hear from people who are interested in joining the network so we can connect them and link them into our process. We typically do our contracting on a 6-month cycle. I know not all the plans do it that way, but another great way to know when that's happening is to sign up for the LA County Roundtable that I co-facilitate with Karen and our facilitation partner, Transform Health. Because anytime we open up for various service networks, we'll make sure that that's announced there as well. And so I would encourage folks on this call, if they're not already plugged into the LA County Roundtable, we meet monthly, that they do that. And I can make sure that you guys get the link for that or the email address.
Yeah.
So we're looking at increasing our enrollment, I guess is the bottom line. Yeah.
Yeah, thanks, Cynthia. And if you want, go ahead and drop that into the chat. We can also capture that and send that out as a follow-up to the whole group that was registered for this. Thank you. I also appreciate hearing about your work on the network side and data mining and contrasting that with sort of what Anwar and Heidi are talking about, where these really high touch outreach, outreach to people who might be eligible for these services. Karen, anything to add? Karen, I think you might be muted.
Okay, there we go. Yeah, I would just echo the same sentiments as far as, at our initial launch was really, to move over a very large population in January. And then looking at the capacity that we had, what we heard immediately was some struggles in working with the health plans and sort of just, although we provided pre-onboarding trainings and operational trainings, and we have the CalAIM roundtables and we have webinars and training every week, still there were some aha moments post go live. And so what we heard is some pushback on some of our contracted partners asking us to please hold and not send new members while they made the adjustment to the new requirements. So really, being flexible with that and understanding, that this takes time for the organizations that were health home providers previously, and even whole person care entities that, needed a time to really understand the nuances of what is required going forward and how to really work with the managed care plans before they felt comfortable taking on new members. So with some of that, I think, we saw some fluctuation in our ability to assign new members. I think a lot of that's ironed itself out now at this point. We've also, are looking at I want to call it like no wrong door approach, and have engaged Find Help as a resource for our organizations to take a look at where we have contracted providers they can refer to. And then, to echo what Cynthia is saying, making sure that primary care physicians, specialists, emergency room departments, hospital discharge planners all know how to identify. First of all know that enhanced care management is a benefit, and they can make a recommendation for a person to receive that benefit, how they would do that. And also what community supports are available, particularly around discharge planning, that, we can connect and provide as a resource. So I think there's just a lot more education that needs to happen so that we can really make sure that people understand how to plug into this.
Yeah, Karen, thank you. You're so good at transitioning me to the next piece, because we're going to talk a little bit about what's next. So thank you all for sharing your strategies and what's been working, what hasn't. I'm seeing lots of questions come in on the chat, but I want to do just a little lightning round. In the next 6 months, what's really on the horizon for each of you? What does growth look like? What incentivizes that growth? Or are you still building? What's really on the table in front of you and your organizations for the next 6 months? I'm going to go backwards. I'm going to start with Karen this time.
Sure. We want to continue our collaboration with our plan partners. We're looking at, IPP investments, right, around creating data exchange enhancements. So how can we ensure that we have greater interoperability and where that makes sense, right? How do we lift up our community-based organizations to be able to easily exchange data? Where can we make an impact there? So we have a lot of collaboration underway with LA Care and key stakeholders around data sharing opportunities, certainly, and building and enhancing our network so that we are able to serve the youth and the justice involved. So obviously that's going to take some efforts and having key stakeholders advising us, right, that have the expertise in managing these populations, building the workforce. And we have, a workforce development stakeholder group that we're launching through the CalAIM roundtables to really take a look at what the managed care plans can do to try to assist in helping from a countywide investment perspective to build out workforce. And then really, how do we meet individually the needs of our organizations and contracted partners? And that continues through IPP funding, ongoing communication with the plan. At HealthNet, what we've done is assign one point of contact in an account manager role to each community-based organization, clinic, county partner, so that they know who to call when they have a question. They know where to go if they have an issue. So we can really hold hands through this process and open lines of communication. I know it can be difficult to navigate with the managed care plans, but I think those are some of the key things that I see we have on the horizon, and just continuing collaboration. More every day we learn about the population, about the best practices, as Anwar shared. And we really try to incorporate that and share that with others.
Mm-hmm. Yeah, thank you so much, Karen. Collaboration, communications, definitely themes in everything you all have talked about today. Cynthia, sort of final thoughts. What's up next for you?
So I'm looking at your questions on the screen, and when I think, what does growth look like? We talked earlier about, I talked about what it looks like for us in the immediate term. So outreach to hospitals and other partners so they know how to come in, looking at our own internal data and how we use that more effectively, and growing the networks for the existing services. But we're also launching new populations of focus in 2023 and new community supports in 2023. So LA Care is launching home modifications and asthma remediation in 2023. And then there's more to come in 2024. So there's plenty of growth already on the docket for us, which is great. But that's something, just so you all have more information about what that looks like for us. What would incentivize that growth? I think we are very incentivized to keep this growing. I think our issue is time, right? How fast can we grow? And I think that is the thing that is, that's the key question. It's just all the things that have to happen to grow at the rate that people want to see it grow. So we're going to, keep doing the best we can to kind of keep up with expectations, but we are, running at 120%, I can assure you, at LA Care. And then what other topics or additional programs are you focused on? I already talked about the community supports that we're looking at. But also, I think justice involved population continues to be something really high on everybody's radar. And something that we'll be talking about a lot more in the coming months is, especially with some of the new directives coming out of the department in terms of folks coming out of jail, pre-release services, post-release enrollment in ECM. For those of you who may not be aware, they are looking at kind of front loading the justice involved assignment so that we know before folks are discharged from jail, what plan they're going to, what ECM provider they're going to go to. So keep an eye out for more on that. And then children and pregnant women is going to be the other really big one in 2023. And we're already ramping up to talk about that. Want to start connecting more with our children focused partners in the community so we can start ramping up, but it's going to be a large population and one where we're going to need a lot of help. So that's going to be also coming up real quick for everybody. So I would keep your ear to the ground on the kids and the pregnant women.
Thank you so much, Cynthia. And I saw, I appreciate you talking about how growth has a couple different aspects, services, populations, and just enrollment numbers. So thanks for sort of underscoring that it's not just one type of growth. And then also the populations that you're keeping an eye on. We had lots of folks, I saw lots of folks in the audience here, very interested in justice involved population and the what's happening there. And also I saw a couple children's folks on here and people focusing on pregnant moms. So I hope they're still on and listening because good to know that you flagged that as well. Anwar, last thoughts.
All right, so part of our new or ongoing strategy is really focused on helping the health plans in the state with capacity building, but with a different spin. So what we're really working on is optimizing the care coordination with all stakeholders, including, like Karen said, find help and hospitals and physician groups, homeless service providers. We are trying to make sure that our system for administrating both ECM and community supports is really focused on quality assurance, because without that, we can't really grow capacity because we're not being effective. So quality assurance and capacity building go together. And that goes the same with working with universities to recruit new workforce, new talent, and also just working on the transparent data sharing, metrics review, being transparent about that with all providers, including the managed care health organizations and the state. And the feedback loop is not a problem at all between CBO providers and the health plan. So I'm happy to report that that is an excellent process, not only with partners, but with all CBOs that I know of that are working with the health plans here in Los Angeles.
Great, thank you, Anwar. And Heidi, last thoughts.
Yeah, I think we're this next year, 2 years, I think all of this work and all of our efforts in infrastructure building and training and is all in service. We're seeing it as in service of alternative payment methodologies in the future. Really building that muscle for having a different relationship with our health plans. I mean, really in the next 2 years, this is intended to transform California healthcare. Mm-hmm. And so it's what Anwar said in the beginning, this is it. This is an opportunity for us to really transform and make it happen and improve care and health outcomes, you know. So we're looking at it. We're, you know, all the other issues, workforce, quality management are part of it. So this is exciting, and we're appreciative that we're part of this network. It's been really transformational.
Mm-hmm. Thank you, Heidi. I really appreciate that you wrapping that up on sort of a hopeful note. Yeah. We have, right, as someone who's gone through this and your organization's gone through this and you're watching it transform the delivery system and the lives of people in real time. So we have time for just a couple questions and we have lots of them, but I'm going to try and pull out a couple here that maybe make sense in the context of our conversation. And just a note for those who have not checked out the chat, there's a lot of activity about that CalAIM roundtable that Cynthia mentioned. So there are links there. I also dropped in a link to all of the roundtables across the state for those of you who are state listeners, but focusing on LA today. So there's quite a bit of information there. Let's see. I know we talked about this, but Cynthia and Karen, just very quickly, and maybe you want to drop or your team wants to drop a couple links into the chat. I don't think you need to go in any great detail, but how do you become a community-based organization contracted with LA Care or HealthNet? Is there an email address that folks should email right now to get more information on that process?
Absolutely, yes. There is a process, and Cynthia and I worked to collaboratively to create a process last year. And so we really, there's a certification application process, but how you would start initially is by reaching out to us. I'll drop the HealthNet ECM ILOS mailbox address in the chat. And then we, we get together, we have a conversation, we find out, what the organization capabilities are, where they're going to be a good fit, make sure that we provide them the information and the requirements, have a couple of meetings. They walk through the certification application process, which can be challenging for some. And so just want you to know that HealthNet will help you to navigate that certification application process. And I know LA Care and the other managed care plans will as well, up to and including, identification of potential IPP funding that can help you to close the readiness capabilities that you need to demonstrate. So I'll go ahead and put the address here for HealthNet, and Cynthia, let you add on anything you want to add on there.
Thanks, Karen. Go ahead, Cynthia.
Yeah, I am looking looking for my addresses. I don't know that I have another team member on here, so I'm kind of
It's okay. We can also send them out as follow-up. No
yeah,
problem.
I'm happy to do that. I mean, that might give me a minute, Katie, to pull that
Yeah,
together for
absolutely.
everybody. But I'm happy to put that. And I think what I will do, since I know Alexis, I see her in the chat, Alexis, who is staffing our LA County Roundtable, I think what we'll also do is see if we can get those mailbox addresses put on the website that we already posted the link to in the chat. That I think would also make it a lot easier. So I will send them direct to you, Katie, but Alexis, maybe we can also talk about making sure those get on the Roundtable website.
Yeah, perfect. And I know we're trying to real-time for Alexis, trying to real-time problem solve. I know they dropped the Roundtable link in there. It looks like registration's closed, but I'm sure the team here will figure something out to try and open that back up. Or
yeah, and they have a Roundtable email address on there as well. So if you guys are trying to get in, I mean, in the meantime, before we get addresses, if you want to email them directly, they can connect you with those too.
Thanks, Cynthia, appreciate it. So last question, we talked a lot about the services and populations that you all are looking at in the next few months, but we have a couple questions in the chat and in the Q&A. What about post-acute care, long-term service, long-term care? Feels like that might fall a little bit in what you were talking about, Cynthia, with hospitals. We also talk about something similar with skilled nursing facilities. And then also, are you trying to reach homebound members with limited or no Wi-Fi as well?
So I can say for LA Care, well, we all know for ECM, those populations are launching on January 1st in terms of ECM care management. At LA Care, we are launching the funding of the actual transition in January of 2024 for those, the two related, the nursing facility and the transition to community for long-term care. But Karen, I don't know what HealthNet's.
Yeah, so HealthNet is launching the two community supports that are relevant to these to the population. And the population in focus obviously is launching for enhanced care management in January 2023. So we are aligning with that population in focus transition to ECM. We're aligning the launch of those community supports as well.
Great. Well, we're right at time. Thank you all so much for this incredible panel and all of your discussion and forecasting and all of the incredible work you are doing every day. So thank you all so much. And I know we look forward to checking in with you all again in the coming months to see how this is going. It's just really incredible to see where this came from conception to starting up and now a year in, and we know that there's so much more to come with CalAIM and transforming this delivery system. So thank you all. Seeing lots and lots of thanks in the chat. So again, really appreciate your time today, and we'll talk to you all soon. And for those of you still with us, thank you all for joining and listening, and take care. Bye.
Thank you. Bye-bye.
Yeah.